Good afternoon, everyone. Welcome to our afternoon webinar. My name is Eleni Angelas. I'm from Suburban Hospitals Community Health and Wellness Department. Thank you for joining us this afternoon. Today we have Dr. Vikram Shenoy, who is an endocrinologist and has an office in the Bethesda downtown location. And he is going to be speaking with us today about building stronger bones and understanding osteoporosis, which affects mostly women, but we'll learn more about it from Dr. Shenoy today. This is a very popular topic among women. So thank you, Dr. Shenoy, for being here today. Before we get started, I just want to go over a few housekeeping items. The first one being is today's webinar is being recorded and we'll make it available on our Suburban's YouTube channel in the coming days. If you would like to watch it or rewatch it or send it to a friend. Secondly, we are in webinar mode, and that means that we cannot hear you or see you, but please use the QA button on the bottom of the screen to ask your questions to Dr. Shenoy. We'll spend the last 15 minutes or so of today's hour answering your questions. And then finally, after the webinar is over, I will send out a link to our evaluation. Your feedback is very important to us. It gives us input on how we can improve our webinar, how we can bring you more quality programming, community health education programming to you. And we are always looking for various topics, hot topics that that affect you. With that, I will take it. I give it to Dr. Shenoy for the presentation. Thank you again, everyone.
Thank you, Lady, very much for introducing me, and thank you very much for having me today. And that's right. Today, what we'll do in the next 30 to 35 minutes or so is go over just different highlights in osteoporosis and just understanding it a bit more in more detail. And as Eleni said, I'm one of the endocrinologists through Hopkins in the downtown Bethesda location. I've been here, I guess, coming up on 3 years at this point, and I see this quite a bit. It ends up being a very common thing to discuss. So first things first, I just have to bring up that I have nothing to disclose. I don't have any investment in anything or any medications or technologies or anything. And what we will do in the coming, again, 30, 35 minutes is go through just all of the different things that we need to talk about when we think about osteoporosis, including how do we define it and what is its clinical significance, and then talking about how do we diagnose osteoporosis, thinking about the risk factors and separating them into what can we control versus what can we not control, start thinking about prevention, thinking about lifestyle changes we can make, start thinking about medications that we can use for treatment of osteoporosis, as well as their indications, and talking through their side effects, and then going through the expectations and monitoring just for bone loss in general, as well as for monitoring treatment. So first thing we need to do is define osteoporosis and think through why does it matter. And what osteoporosis is, just by definition, is it's a disease of poor bone quality and low bone density due to bone loss. And in this disease, bones are becoming brittle, weak, and fragile. And the first thing I want to do is highlight that osteoporosis and osteoarthritis are very different processes and different diseases. So osteoarthritis is wearing down of the joints where the bones meet, whereas osteoporosis is a problem of the bone itself and the bone quality. With that understanding is that bone tissue is very dynamic and it's constantly remodeling. The bone tissue you currently have is not the same as it was 10, 15, 20, 30, 40 plus years ago, because that would be old rotting bone. We like to use an analogy of the grocery store produce section where the lemons and limes on the shelves are picked over and fresh shipments come in, and the lemons and limes in the grocery store are not the same ones from when the store originally opened years or decades ago, because they would be rotten. But instead, what happens in osteoporosis is a mismatch between the two types of cells. The cells that build your bone, which are called osteoblasts, and then the cells that break down your bone, which are called osteoclasts. And this mismatch leads to loss of good, normal, healthy bone structure and leaves the bone porous or vacant. And then it can't handle certain traumas or weight, and the bone can be susceptible to fracture. And again, coming back to our grocery store analogy, if you have healthy lemons and limes, they get picked over as they get expired, they get cleared out by the bone breakdown cells, and then a fresh shipment comes and the shelf is refilled. That's your bone building cells. In osteoporosis, the good, healthy, fresh lemons and limes are getting cleared out prematurely, and the next shipment of good, healthy lemons and limes are not coming for some time, and that shelf is left vacant. And the trouble with this disease is it's often silent until it's not, and that's a fracture. And that's thinking through why does it matter? And what we want to do is talk about clinically reducing the risk of fractures. Because osteoporosis ends up causing about 2 million fractures each year in the United States, of which about 500,000 are going to be vertebrae fractures in the spine, usually compression fractures for different reasons. Sometimes the bone is just not strong enough to support your own body weight, or minor traumas, fender benders, falls, slips, trips, etc. And what we see in the photo here in the model is a vertebral fracture, which is looking at the compression and not necessarily an issue with the disc in between the vertebrae, but rather in the vertebrae itself. And then we think about osteoporosis causing hip fractures. There's about 300,000 per year. We'll talk about why that's a problem in a moment. About 400,000 wrist fractures, most commonly from falling. And then over 800,000 other types of fractures in the arms, the legs, the collarbones, the hands, feet. And ultimately, what we see is that it's estimated about 1 in 2 women and 1 in 4 men over age 50 will have a fracture. And so as we think through even more, why does this matter? Fractures can lead to severe pain, often requiring surgery, and then in turn can lead to chronic pain, deformities, disabilities, and potentially death as well. What we see here in the picture is a hip fracture, and this is the ball and socket joint going into the pelvis, and there's a large crack through the femur bone here. And now obviously this is going to be very painful. But even more worrisome is that it's about 50% of patients with a hip fracture are not going to be able to walk without assistance again. About a quarter of patients with hip fractures end up requiring long-term care. And then one of the most terrifying statistics I know in medicine in general, with regards to everything from diabetes to heart disease to cancers, etc., is this statistic with regards to osteoporosis and hip fractures, which is that if you break a hip beyond age 65, the risk of death within 1 year of the hip fracture is about 30%. And studies have shown that number up over 40%. Studies have shown that number down at 15 to 20%, but still a large percentage, which is very, very frightening. And the reason is not the hip fracture itself, but rather everything that comes along with it. So we think about a hip fracture needing to go in for emergent surgery, not usually time for surgical clearance. Ultimately, you might uncover unknown heart disease or cardiovascular disease, which can result in a heart attack or a stroke. After the surgery, we worry about blood clots from immobility. We worry about pneumonia just from not being able to take deep breaths due to pain. And again, because of immobility, we worry about wound infections, and we worry about loss of independence. And bone and muscle and your mind, especially, are really important to know that if you don't use it, you lose it. And if you're not able to function, you start deteriorating with muscle mass loss, bone loss, and it can become really, really bad. And so I've substantially scared you enough so far. We'll start talking about how do we find it and what do we do about it. And what we have here is a DEXA scanner, which is going to be the primary tool we use for diagnosing osteoporosis. So DEXA, or DXA, stands for Dual X-ray Absorption Scan. And what it's going to do is you would be positioned flat on the table here, and they would take pictures of your back. And then they would put your legs up on a block to be able to take pictures of your hips. And they fire some X-rays down to the bone, and they measure how much gets reflected back by good, healthy bone. The denser the bone, the more comes back, versus how much passes through. And more porous or vacant bone is going to allow more X-ray to pass through the bone. It's extremely low radiation. It is not similar to a CAT scan. It's more similar to just a routine X-ray. And the calculations that we get as the X-rays come back here allow us to measure the bone density, which is given as grams per square meter. We then take that number and normalize it based on age to give us what are called T-scores. And T-scores compare what is your bone density compared to the peak bone density, which is usually around 30 to 35 years old. And we measure how many standard deviations away from the peak are we. Again, generally the spine and hip will be measured as routine. Sometimes the forearm gets measured as well in certain medical conditions, like an overactive parathyroid gland, or if there has been back surgery or hip surgery already with hardware, that can influence results. Or sometimes if there's really significant arthritis, that can influence results, and we would use the forearm as another marker. With regards to the T-scores, again, how far away from the peak bone density are we? Normal bone density is anything greater than -1. And we use negative scores because we're talking about bone loss. So anything above -1 is still considered normal. We expect that not everybody has the same peak bone density. We expect that just with natural aging, there's going to be some bone loss. After women have menopause, we expect there to be some bone loss. But how much bone loss dictates where do we fall on the spectrum of bone loss and bone conditions, bone quality. So greater than -1 is normal. A T-score between -1 and -2.5, technically -2.4, is going to be osteopenia. So that's mild bone loss. And then a T-score of -2.5 or below is osteoporosis, which is severe bone loss, and that your bone is more than 2.5 standard deviations away from the peak, or really the bottom about 2 to 3 percentile based on statistics. So who should be getting DEXA scans? This is the recommendation from the United States Preventive Service Task Force. And this is the committee that also helps guide for mammogram timing and colonoscopy timing. And so they also give us guidelines for osteoporosis, which end up being fairly strict with what they recommend. And they really recommend screening DEXA for any woman over 65. However, they recommend a sooner DEXA for any woman younger than 65 who is postmenopausal and has a risk factor for losing bone. So we'll talk about those risk factors in a moment. For men, they actually don't have a recommendation in there. But the National Osteoporosis Foundation actually has a little bit more leniency in what they recommend. And I'm more in this camp in terms of screening because it's better to know and do something about it than not know that there's a silent disease process if we can proactively be doing something about it. So the National Osteoporosis Foundation ends up saying similarly, if you are a woman over age 65, postmenopausal woman with risk factors, even if you are not quite 65. But then they also add in men 70 and older, period, with or without risk factors. They actually say men 50 to 69 with risk factors should be screened. And then ultimately, patients who have broken bones beyond age 50, mostly looking to see is there something underlying in the bone that should be treated as well. As we think about the risk factors here, and these have been copied in from the National Osteoporosis Foundation, what they consider, most of these are going to be things that you don't have in your control. Unfortunately, just as we age naturally, we're expected to lose some bone. And unfortunately, we don't have the time machine to go back. We're already now, I don't know, 10, 15 minutes older than when we started. Women are at higher risk, partially because of menopause. And menopause, up until menopause, the ovaries give estrogen, and estrogen is a protective force field on the bones that helps prevent the other organs from stealing resources out of the bones and using them, the protein, the calcium, the other minerals. And so after menopause, that force field is gone, and the rest of the organs look at the bones as this great treasure chest to steal from. A lot of it's going to be family history, especially family history of osteoporosis itself or broken hips. Unfortunately, some of these things are just in the cards, in the DNA program that your body has already written for you. And then just a more petite stature and just smaller bones end up, unfortunately, being more prone to osteoporosis as well. As we start looking over at the next column too, there's a whole wealth of different types of medical problems that can lead to bone loss too. And ultimately what happens is, especially if you're young and you're diagnosed with osteoporosis or breaking bones, these things should be looked into. This is called a secondary evaluation, evaluating for different things like autoimmune problems with generalized inflammation that can steal and leach from the bone, endocrine problems such as hyperthyroidism, overactive thyroid, hyperparathyroidism, or overactive parathyroid glands, which can steal from the bone. Low testosterone in men, because testosterone is going to be the protective force field on the bone for men. We can see it as a risk factor from uncontrolled diabetes. We see it in patients who have absorption trouble, so whether that's celiac disease, Crohn's disease, patients who have had bowel resections for different reasons, patients who have had bariatric surgery for weight loss. The absorption of the nutrients ends up being different. We think about the bone marrow itself, and can things be leaching from inside the bone? We think about neurologic disorders, which might lead to more immobility. Again, we talked about bone being, if you don't use it, you lose it. And then we can see it from chronic kidney disease. We can see it from cancers. We can see it from eating disorders. We can see it from HIV. And then the trouble is the flip side over down here is that the treatment for a lot of these medical conditions can also cause bone loss. And that could be steroids, long-term use of prednisone, very frequent joint injections, things that can be used for arthritis or autoimmune problems, thyroid medication, seizure medication. We can see it from chemotherapy. We can see it from radiation for women or men who have had breast cancer. We can see it from the estrogen-depleting medicines, which are called aromatase inhibitors. These are like anastrozole, tamoxifen, exemestane, letrozole. We see it from anti-acid medicines which reduce acid in the stomach, and that can change how much calcium you can absorb. So those are proton pump inhibitors, commonly like omeprazole or Prilosec, esomeprazole or Nexium. We can see it from SSRIs, commonly used for depression and mood. And we can see it also as a warning from a certain diabetes medicine called pioglitazone, which is a thiazolidine dione, this word down here. These have kind of fallen out of favor, so we don't really use them as much. But moving on, so I mean, a lot of that is going to be things that are out of your control. And so we start thinking about what do we have in our control? Because your bone density, it is a big game of tug of war going on. A lot of things that we do to try to improve it, but a lot of things that go on that are trying to make it worse. We have to figure out how do we win that game. So I like to think of these as the 4 pillars for just prevention, and these are things that everybody should always be doing. And ultimately, I highlight fall prevention first. I know nobody is actually actively trying to fall down, but with everyone I see with osteoporosis, I tell them I want to be in your head to be very, very careful. And I say that very tongue in cheek, but also just from a place of love. That one fall, if you get bumped, if you slip, if it's flip flops, if it's a rug or a carpet that's curled up, or throw rugs, or mats, or pets, fall risks are everywhere. And we just get so busy and we often get distracted. Somebody is calling you, somebody is texting you, something else is happening across the street, whatever it is. And without warning, you fall, and that can be a life-changing, devastating type of injury. So fall prevention is key. The paradox is we do want you to exercise because we talked about bone being, if you don't use it, you lose it. So stimulating the bone, we'll talk about that more in a moment. And then making sure that the bones do have enough substance to be stronger with calcium and vitamin D. If we think about targets here, calcium first, what we're actually doing is not looking at the blood calcium level on your labs, because your parathyroid glands are pretty much always going to try to keep that normal. If your blood calcium level is off, then that's a different problem, and we'll talk for another time. But your blood calcium level probably will pretty much be normal because your parathyroid glands are doing their job. But they're going to do their job at any cost, which is to say they don't care about your bones, they don't care about your brain, your heart. They just say, we want normal blood calcium. If we don't get enough calcium into our system, your parathyroid glands say, okay, well, we're going to go steal it out of your bone. This is where getting enough calcium ends up being important. The general target is about 1,200 milligrams a day in total, which is from your diet plus supplementation. And in the diet, we think about things like dairy products, cheese or cottage cheese, milk, yogurt, ice cream, if you're not diabetic. Alternate dairy products like almond milk, oat milk, soy milk are usually going to be supplemented or fortified the same way as cow's milk, which for dairy, it's usually going to be about 300 milligrams per serving, depending on your serving size. We think about fatty fish like tuna and salmon. We think about nuts, except for peanuts, which are technically not nuts, they are legumes. But nuts like almonds, pistachios, walnuts, pecans, and then dark green vegetables, pretty much anything but lettuce. Generally, we're going to see about 200 milligrams per serving here, depending on your serving size again. And sometimes it's helpful to just play that game of how much calcium do I think I'm getting, do that over a couple of days, keep track. And if you're falling short of 1,200, then you start thinking about either adding some more food as medicine, or you start thinking about a supplement, such as calcium citrate, or even Tums count. Although with Tums, you have to be careful because the whole pill is not calcium, only 40% is. So 1,000 milligram Tums, an ultra strength, is only 400 milligrams of calcium. 500 milligram regular Tums is only 200 milligrams of calcium, and so forth. Vitamin D, we start thinking about targeting a level in the blood over 30. Vitamin D is really important for your body to see the calcium coming into your gut and be able to absorb it. So vitamin D is actually not a vitamin. It's actually a hormone. A hormone is just a loose term for something that works somewhere else in the body. So vitamin D gets activated in the skin once, or we bring it in as a supplement, and then it gets activated by the kidneys again. And once it gets double activated, it comes to the stomach to allow for the absorption of calcium. If you're very vitamin D deficient, your body cannot absorb the calcium you're getting. And then your parathyroid glands again say, well, we will go steal from the bone if we can't get the calcium from your food. So most patients will end up needing like 1,000 to 2,000 units a day, sometimes up to 5,000 units a day, which ends up being over the counter. For severe deficiencies, levels below 20, we look for prescription strength, which is going to be 50,000 units once a week, generally, and with the level checked again after like 3 months. And that's a prescription from your provider. Exercise-wise, weight bearing ends up being really important when we start thinking about things against gravity. So our skeleton prevents us from being puddles on the earth. So walking is great because your feet are pounding down onto the ground. Same with jogging, resistance or resistance bands, light weights, even things against body weight like yoga and Pilates. We end up not seeing quite as much benefit from things where your body is suspended more, things like elliptical machines, cycling, and swimming, where the resistance is more going to help your muscles. But ultimately, what we're seeing is more so your bones rolling around in their ball and socket joints of the shoulders and the hips. And then, of course, fall prevention. So you heard it from me twice. So those are going to be preventive things we think about. When we start thinking about medications, we start thinking, okay, when is medicine actually going to be indicated? And really, the general rule of thumb is pretty much everybody who has an osteoporosis diagnosis should at least be considering treatment, because these are going to be the highest risk of fracture. It doesn't have to be perfect, and something is better than nothing. There might be a recommendation one way, but you might be uncomfortable with potential side effects, or just based on other things going on with your health, it might not be the best option for you. But the goal here is to be proactive, recognizing that osteoporosis is a disease, often silent until it's not. And another analogy I use here is that think about blood pressure, which is often silent, but left uncontrolled over years, decades, you can have a stroke, a much more devastating outcome. And not that everybody with blood pressure ends up having a stroke, but if you can proactively keep it controlled to reduce your risk, you probably would. And it's the same thing here with osteoporosis, where not everybody with osteoporosis will break a bone, but the risk is much higher. And if we can be proactive to reduce that risk, it's important, recognizing what we had talked about, especially with hip fractures, that if you do break a hip, there's a very real risk of lifelong deconditioning, disability, and or death. And so that's why we think about being proactive here. For patients with osteopenia, it ends up being a discussion. And we calculate what's called FRAX, or fracture risk assessment. This is going to calculate what is your risk of breaking a bone over about the next 10 years. And we count a 20% or above risk of any type of fracture, or a 3% or above risk of a hip fracture at high risk. And this is something that the radiologist will often do, and you might see on a DEXA report if you have osteopenia. It's called FRAX, or fracture risk assessment, FRAX. And there's just an online free calculator which you can use. And it goes through a lot of different things with normalization for where you are. So based on demographic and region, your age, male or female, your weight, your height, and then a lot of different risk factors in here where have you broken a bone before? Is there family history of hip fracture? Smoking ends up being a risk factor as well, as does alcohol, more than 3 beverages a day. Thinking through chronic steroids like prednisone, which we talked about, autoimmune problems, or other secondary causes of bone loss. And then the DEXA result with bone density. And that gives you a result. And then finally, we think about patients who have already had fractures. So if there's been a hip fracture, a vertebral compression fracture, or other long bone fracture of like the wrist, the collarbone, the arm, the leg, with minimal trauma, where you say, that doesn't make sense, this shouldn't have broken, we start thinking about at least screening and potentially treating. And medication-wise, we're really targeting either the cells that build the bone or the cells that break down the bone. And we had talked about how they work together, and the cells that break down the bone are working harder than the cells that build the bone. So here are the osteoclasts breaking down. That's called bone resorption. Here are the osteoblasts building the bone, which is called bone formation. And either we can stimulate these or we can slow down these. So this is a little bit busy, but we'll talk about everything. This is just to kind of give you comparisons. And when we think about bone building medicines, there's really two types. One class are called teriparatide, also called Forteo as a brand name. The other is abaloparatide, or Tymlos as a brand name. And these have been approved for some time, especially Forteo. It's been out for more than 2 decades. We know quite a bit about it at this point. It works by directly stimulating the osteoblasts, and both of these medicines are taken as a daily injection under the skin at home. They come in these auto-injector pens like this, where you dial up the dose. You would learn how to inject. It is a little bit of inconvenience that way, but it is a very good bone protective medicine, especially if you are having frequent fractures. Ultimately, you get treated for 1 to 2 years and reassessed along the way, keeping an eye out for things like nausea, headache, dizziness. We think of high blood calcium as well, because they are stimulating parathyroid hormone, which is seeking calcium as well. And then in early clinical trials, we saw a risk of osteosarcoma, which is a rare bone cancer. It was happening in rats. We said, interesting, let's see what happens in humans. And for teriparatide, in this time, they've been looking at it prospectively as we go into the future. And we actually have not seen that increased risk in humans. And so they've actually removed the warning of osteosarcoma from this medicine, but it is something we still keep an eye out for, mostly with blood testing. You can actually screen with blood testing for that with your metabolic panel and an enzyme called alkaline phosphatase, which in this problem gets really high. Like normal is up to 120. We see that number is 800 or 1,000, and that raises a red flag. But otherwise, the other medicine is called Evenity, which is the newest of the osteoporosis medicines, although it did get approved in 2019 at this point, so it's been around for some time. This is an antibody against sclerostin, and sclerostin is a natural protein your body already has that inhibits the bone building cells. So if we inhibit the bad guy, it allows the good guy to work, and that's the theory here. It is given as a monthly injection, either in office or in an infusion center, and the treatment is monthly for 12 months. Similar type of side effects with nausea, headaches, dizziness, achiness. And then there is a warning on this medicine for cardiovascular disease because of an increased risk of heart attack or stroke actually seen from it. So it is a double-edged sword. That risk is low, but we do say that if you've had a heart attack or stroke within the last year, this medicine is actually contraindicated. Ultimately, the bone building medicines are actually used for more severe cases of osteoporosis. T-scores below minus 3.5, so more severe type of osteoporosis, much lower bone density, 3.5 standard deviations below the peak, or patients who are failing the bone breakdown medicines, which we'll talk about in a second, or patients who are having a lot of fractures. So these end up being more potent types of medicines. More commonly, what we're going to use are medicines that slow down the osteoclasts, which break down the bone. We tell them don't do that. There are 2 classes of medicine here, which are going to be bisphosphonates and denosumab. With bisphosphonates having a lot of different names, most commonly there's going to be Fosamax, the brand name of alendronate, Actonel, the brand name of risedronate, or Boniva, which is the brand name of ibandronate. These are all pills, with Fosamax being taken once a week by mouth, Actonel and Boniva being taken once a month by mouth, And then reclassed being the IV form of these medicines. The pills got approved in the 1990s, so we know quite about a bit of them as well. Reclass got approved in 2007. What we know about these medicines is that you only get them for a maximum of 5 straight years, and then you get a break from them. You want it to clear out of your system. As we manipulate the bone cells with these bisphosphonate medicines, they linger in the bone and they can start to create defects in the bone if the bone cells start making mistakes. So there are two rare risks that we see. One is called an atypical femur fracture, which is a paradox. The other is called an osteonecrosis of the jaw. And if these bisphosphonates are lingering in your bones more and more and more, and the bone cells start making mistakes, they can create a defect that can make the bone snap. It's exceedingly rare that we see these. They're on the order of somewhere between 1 in 25,000 and 1 in 100,000, whereas your risk of breaking a bone, as we talked about, is 20% plus probably from osteoporosis. So it's totally different orders of risk, but these medicines have been around for long enough that we do know to keep an eye out for these things, keep tabs of how long you're getting them, and make sure that you are given precautions of what to look for and stay up to speed with your dentist, such that if you're getting invasive dental work done, making sure that your dentist knows you're getting medicine that might impair healing, and talk with them and talk with your provider of what do you do with your medicine in the meantime. Other side effects with regards to the oral bisphosphonates are going to be generally achiness or heartburn, which can happen sometimes. It's rare. I mean, one patient every maybe 6 months or so will tell me they don't want to take it anymore, which is fine, and we figure out a different plan. We don't want it to ruin quality of life. And for the IV forms, like reclassed, we worry about kidney function. So if you already have chronic kidney disease, probably not a great choice. If you're dehydrated at the time of the infusion, it can actually cause worsening kidney problems. So heading into an infusion, we say stay well hydrated, make sure that your kidney function and your blood calcium are checked within usually 60 to 90 days of your infusion for it to be valid. And then after the infusion, looking for an infusion reaction, which happens in about 25% of patients on their first infusion, giving flu-like symptoms, like after a vaccine, some achiness, blah, low-grade temperature type feelings, which goes away within a day or two and usually gets better with acetaminophen, but not dangerous to you. The other medicine that stops the bone breakdown is denosumab, which is given under the brand name Prolia. And this was approved in 2009. It's whenever you see the word mab, it means it is an antibody, like romosozumab, which builds the bone. So this is given as an injection every 6 months in an office or infusion center. The catch with Prolia is it's kind of forever. What we know is once you start Prolia, if you suddenly stop it, you rapidly lose bone. So the gains that you see end up going away and reversing pretty quickly. It does not linger in the bones for a long time the way bisphosphonate medicines do. If, say, you don't tolerate Prolia, or if you get much better with bone density on your DEXA scans and you want to try to get off medicine, you cannot go from Prolia to nothing, but rather you can go from Prolia to something else to seal in that Prolia and then step off. But what the studies show there too is that you still see a little bit of decline, maybe not quite as much, but so it ends up being less ideal to do it that way. So it is a long-term commitment. We know there's at least 15 years of safety data now because this is another one they are prospectively watching to see if there increased risk over time. So far, we do not see that. It does have the atypical femur fracture and osteonecrosis of the jaw, rare side effects, but those risks also do not increase over time. The other things with Prolia we look for are going to be general achiness, low blood calcium, which should not be a problem if you're getting enough in your food, drink, plus minus supplement. And then in the clinical trials, we saw some mild infections like urinary tract infections, and we don't really know why. We don't really see that in the real world, but another precaution to look out for. There's some other medicines that do exist, which we'll briefly walk through. One is called raloxifene, and this one helps on the estrogen receptors to try to regenerate that force field on the bone. It's fallen out of favor a bit because we don't see that it really helps reduce hip fracture risk. It only helps reduce vertebral fracture risk. It's taken as a pill daily, and a lot of times the benefits and risks of this medicine are a little bit in a gray zone where there's an increased risk of stroke, blood clot, and other symptoms like hot flashes, swelling, which is similar to hormone therapy too, if we think about giving estrogen back. And in ladies who are perimenopausal or newly menopausal having trouble with symptoms of menopause, we do see that estrogen can be helpful and preventive for osteoporosis at that time. But if we see osteoporosis, we don't use estrogen as a sole treatment because other medicines that we just talked about end up being much more effective at reducing fracture risk without all of these other side effects that estrogen can give you. Again, things like blood clotting, stroke risk, risk in the breast, risk in the uterus for cancer. And there's an older medicine called calcitonin, which is no longer used for osteoporosis. Again, same reasons. Other medicines are just better. But we can use it if there is pain from vertebral compression fractures. It's given as a nasal spray, really just for up to 4 weeks, temporarily. And when we think about monitoring the bone density, it depends on where do you start. And with better bone density at the beginning and less risk factors needing less monitoring, and worse bone density at the beginning or assessing treatment response needing more frequent monitoring. So if you start with normal bone density and don't have any risk factors, we say get another DEXA in about 10 years. Now, obviously, if there's a new risk factor that comes up, maybe you get one sooner. If there already are established risk factors, we say about 5 years for the follow-up is fine. If there's osteopenia with a high FRAX score, F-R-A-X, fracture risk, or if there are risk factors, if there's breast cancer with treatment, there's hyperthyroidism, hyperparathyroidism, chronic steroids, autoimmune problems, all of the things we talked about. Or if you're being treated, we think about a DEXA after about 2 years. If there's no risk factors and it's just mild bone loss, 3 to 5 years ends up being okay for the follow-up. And then finally, for osteoporosis itself, we say a DEXA at least every 2 years, and that's generally what the insurance will cover. But we often have success getting 1-year DEXAs approved based on severity and treatment, with documentation from your provider citing that we need to know at 1 year because it will change the management to potentially be more aggressive, to be able to potentially change your treatment plan or regimen, and we need that data. When we think about the expectations, what are we looking for? This is going to be the general progression of bone growth and then bone loss that we see with time, with the peak bone density usually between 30 to 40 years old. But then women through menopause end up having this rapid bone loss, and that's why 65 becomes a cutoff for definitely having a bone density scan. And then there also happens to be this gradual bone loss as well over time. Because of this expected bone loss with time, if we get DEXA scans that show stability and not loss, or if we see some improvement in the T-scores, that's a victory. If you don't see improvement on the DEXA, what we actually know is that treatment with medicine for osteoporosis or high fracture risk actually still does give you fracture risk reduction. And clinically, that's really what our goal is. And the medicines, depending on what type of fracture you're evaluating, depending on what you're looking into, the risk reduction is somewhere between 35 and 70% less fracture risk by being on medicine. However, if your bone density is worsening with treatment, or if there's new fractures on treatment, then you start thinking about changing to something else that might be more effective for you. If you do break a bone within the first month or two on a treatment, I would not necessarily call that treatment failure. But if you've been on treatment for 1, 2, 3 years and you newly are breaking something and it was not a significant trauma or something would have broken anyway, then it's time to start thinking about maybe needing something even more potent. So, in summary, here, osteoporosis ends up being really common, and complications, unfortunately, can be life threatening or life changing. And about 1 in 4 men and 1 in 2 women over 50 will have a fracture. So, we start screening in women at age 65, age 70 in men, or sooner based on risk factors. And everyone needs to be protecting their bones. If you don't use it, you lose it. So, weight bearing exercise is important in order to stimulate the bone and absorb the supplementation. We think about calcium and vitamin D. Fall prevention, you're hearing from me now a third time. Please don't fall, do whatever you can. And then we start thinking about bone treatment in patients with osteoporosis, osteopenia with high fracture risk, or who've already broken bones. And then we monitor based on how severe it is when you started, with more severe cases needing more frequent monitoring. And so with that, I thank you for listening and having me here. I'll take some questions.
Thank you. Thanks, Dr. Shenoy. I, this is very, I'm very helpful. I have some questions from our audience. And then I have some questions as well, so I'll be quick. Is it okay to stay on Prolia for more than 10 years? I have no side effects and it would like to remain on it. If not, why?
Yeah, great question. And generally what the guidelines are telling us now actually is keep going with Prolia. We're not seeing any unusual or new types of problems. And if you're tolerating it well, you can keep going. We know we have at least 15 years of safety data so far. With each year that passes, we're just continuing to get new data. Obviously, at some point, with the patients who've been getting it at the cutting edge of that line, if we start seeing some uptick in some problems, then it's going to become known, and we would say, okay, well, let's not go that far with treatment. Let's talk about a different path forward. Great question.
Now, along the same lines, how often should a DEXA scan be repeated if you're being treated with Prolia?
So with Prolia, generally, I mean, the rule of thumb is going to be every 2 years if things are pretty stable or improving with your bone density. But if there's a fracture or if you are losing bone and we need to think about potentially changing treatment, at that point you start thinking about a 1 year DEXA and documenting that it should be getting that we need that 1 year DEXA because it might change your management. But generally the standard for Prolia, because it's going to be pretty effective, and if you see stability or improvement, would be every 2 years.
So with these medications that are like a 1 year treatment, 2 year treatment, once you get off of it, is it supposed to kind of like you're just not going to lose bone density as frequently, or is it just going to keep building it?
Yeah, so they will still continue to trickle out of your system. They will remain in your system for some time, but a lot of them, it's a really good question, like especially for the bone building medicines, which are 1 to 2 years for teriparatide, abaloparatide, or 1 year for romosozumab, which is Evenity. We often follow it up with something else to build and then protect, and then maybe step off of the treatment. And those situations end up being helpful for the 1 year DEXA as well, because those bone building medicines are going to be more so for patients that have severe osteoporosis already and need that potent medicine. And that 1 year DEXA will definitely change your management for what do you do next.
Great. Another question, could osteoporosis patients in the DC area get Prolia and reclass treatments at Suburban and Sibley?
Yeah, absolutely. So we have been referring to Sibley for reclassed. Suburban, unfortunately, the infusion center is no longer there for osteoporosis treatment. I'm not actually sure if they have one now even for cancer treatment. So, because I know the cancer center is at Sibley,
Mhm.
but there's a GI infusion center at Sibley, and we've been able to refer to Sibley for reclass or to Columbia, Howard County. For Prolia, we actually give that in our office, but otherwise,
Okay.
infusion centers can also give it.
Okay.
Mhm.
How do you use biomarkers to assess BMD status?
So, bone markers, we can use things like C-telepeptide, which is a blood test, or NTX, N-telepeptide, which you can measure in the urine. It can be helpful sometimes for guiding your next steps. So with medicine like reclassed, which is usually a once a year infusion, if you think that somebody is getting too much medicine, you can use a bone turnover marker to guide you and see, is it turning off or turning down the bone turnover too much? You don't want the bones to make mistakes that increases the risk of the atypical fracture. And if you measure a number like CTX like once a year, it can kind of give you an idea of what is the bone doing at that time. Up front, measuring a number like that can be helpful too, just to kind of see how quickly do we think bone is being lost, and that might increase the urgency for measuring. But definitely a helpful test, and we'll use it in different situations.
Boy, we have some questions that keep coming.
Mhm.
Um, why are vertebral wrist and hip fractures called typical osteoporotic fractures, but skull and clavicle fractures raise suspicion of another pathology?
So, really, any fractures in general, a lot of times, if you're breaking a bone for seemingly no reason, I'll often go forth with the secondary evaluation to make sure something else, another pathology, is not happening. But ultimately, the clavicles and the skull are not necessarily going to be weight bearing parts of the skeleton. The wrists end up having to like brace yourself, and so even like minimal trauma here, if you hit them, it's not going to be typical to break collarbones that way. Usually, collarbones end up being trauma, and then skull fractures usually the same. Um, but ultimately, with hips and spine, we're thinking about them being weight loading areas, and then same with the wrist to a degree, especially because our natural tendency is fall this way. To my knowledge, that's what I understand. I'm not really sure why else, though. It's a good question.
It's a good question, but I think it has to do, yeah, like just when you fall, you're not going to necessarily, you're going to use your arms and your hips to break your fall. So not your clavicle or your head. Um, that's a good question. I want to get to everyone's questions, but just for those who are perimenopausal or soon to be or in menopause, when is it best? What kind of doctor, which doctor should perimenopausal women go to? Should they go to their gynecologist or an endocrinologist for a discussion about estrogen, osteoporosis, protection? Which doctor should we go to? Should it be, or it could be either, but I'd like to hear what your thoughts are.
Yeah, absolutely. I mean, there's definitely a lot of overlap with different things, kind of similar to other conditions too, where there's overlap between heart doctors and lung doctors, or orthopedists and rheumatologists and sports medicine doctors and such. So this is one of the kind of overlap areas between gynecologists and endocrinologists, and really either can do it. Where gynecologists generally have the advantage is going to be more honing in on women's health monitoring in terms of breast cancer screening and risk assessment, uterine and ovarian pathology screening, and uh, assessment and evaluation and monitoring too. But really, either can, and a lot of it ends up being co-management.
Okay, thank you.
Yeah.
Um, after this participant writes, after 5 years of Fosamax, how long to stay off it, and then what happens with treatment? And I think you mentioned it a little bit, but just to expand on it?
Yeah, generally you stay off of it for a year or two. In that time, you get a DEXA scan and you see how um, how does that how do things look, and you decide, do you go back onto it, do you change medicine? If you're reaching that 5-year point on treatment and you still think you need treatment because maybe you had a fracture or bone density really hasn't improved, you're still in the osteoporosis range, you start thinking about just changing therapy to something else. But ultimately, general rule of thumb, after 5 years, we say 1 to 2 year break. Keep an eye on your bone density in that time. It's still going to give you protection over that time. It's ultra long lasting.
Mm-hmm.
And then once it finally washes out, then you can always resume medicine and the clock resets if you do need it again in the future.
Um, this participant writes, I was given I'm sorry. I'm sorry about my pronunciation. Stopoclo instead of Prolia as a generic for Prolia last time. Are you familiar with that?
Ultimately, I've heard of it. I'm not too familiar with it. It's not something that I've prescribed because it's not something we get into our office. It's the way that we operate. But generally going to be effective as well the same way.
Okay. And Dr. Shenoy, what causes low CTX?
So CTX is going to be the C-telepeptide, which is the marker of bone turnover. And there can be a lot of different things for that. So one could be if you're on treatment and treatment's effective and it's not high, meaning that if CTX is very high, it means that your bones are turning over quickly. It could mean hyperactivity from osteoclasts, which need to be turned off. If you're seeing low CTX, it means that maybe they are more dormant, maybe treatment's being effective for them. But the other thing that can do it too, we actually see this with chronic kidney disease. And patients with chronic kidney disease can have what's called CKD-MBD, which is chronic kidney disease associated metabolic bone disease. And in these patients, we can actually just see that the bone turnover isn't that much because your kidneys and how they handle calcium and phosphorus and what they do with relation to the bone and how they deposit in the bone, the whole metabolism there gets messed up a bit. And in those patients, you end up having to be very careful because if they have a really low baseline CTX from chronic kidney disease, starting treatment can actually be harmful. It can actually increase the risk of atypical fractures and creating kind of more of a paradox. So there's different reasons for it, but most commonly, if it's because you're on treatment, it's usually going to be because of the treatment.
Okay. Why is a DEXA scan needed every 2 years while on long-term polio treatment? I'll read it again. Why is a DEXA scan needed every 2 years while I'm on long-term polio treatment, which has improved my bone density?
So bone is dynamic, things can change, and so we just need routine monitoring. That's really why, making sure that it's still effective for you, making sure we're not missing something else. It's the same way that if you start blood pressure medicine, you're not going to never check your blood pressure again because you started blood pressure medicine for it. Same way with blood sugar. If you're diagnosed with diabetes and it's controlled, you still continue to check that routinely. Same thing with the bone density, just routine monitoring.
Okay, perfect. Why do bi is I'm so sorry. I feel like I'm going back into my biology class. Or chemistry rather, bisophosphonates, which suppress bone reabsorption, sometimes cause atypical femoral fractures with long-term use.
So this is kind of highlighting again that they're ultra long lasting medicines. They just sit and linger in your bones for a long time, and they just continue to manipulate the bone cells. The bone cells make mistakes in the bones. They create defects in the bones. So if you think of a brick, here's another analogy for you. If you think of a strong brick, you can't break it with your hands. It's strong. Sure, if you bring it to the top of a 70-story building and throw it to the sidewalk, it's going to break. That's trauma. That's expected. But an atypical fracture is there's a defect. Now, if you have that same brick and it's made incorrectly, internally there's a crack or something that's gone wrong in its manufacturing. Now you take it with your hands and you can just snap it in two. And that's what we fear. And so that risk increases beyond 5 straight years. So at 5 years, we need to back off the medicine, let it clear out, allow your bone cells to kind of resume normal procedure, and then figure out, do we need to stop them again?
Thank you. Thank you for the analogies. I really like the analogy of the the produce, like the bones are keep their the bone cells keep growing and there you go. I really enjoyed that. That was a great analogy because that really puts it tangible. Um, that's all the time we have for today. Thank you. Thank you, Dr. Shenoy, for being here with us this afternoon. And I appreciate everyone's time as well. So we'll say goodbye for now and see you soon later.
You
Thank you,
too. Thanks
everyone.
for having me.